Welcome back to the MedTech Jam Session.
Good to see you, Mike D.
Great to be seen.
MedTech Jam Session, where the future comes to scream.
I had to turn it up just for a second.
It is the summer. It is the summer.
It is a summer, and it's about 180 degrees here in Memphis. 200% humidity.
200%.
Oh my God.
It's bad.
What are we doing?
I know. We got at least a week of this before maybe something changes. I don't know.
Yeah, man, probably another 6 weeks.
Yeah, exactly.
Well, good, man. It's great to see you. It's always great to be back and having a chance to chat with some great founders and CEOs and builders and creators. We got another great lineup today. We're getting back into talking about some enabling tech. And I think this one is going to be a little unique because it's not the traditional, the physician is the customer or the hospital system. There's a wide range of customers for this particular technology and solution that I think is really, really compelling.
Yes.
And
I would say, everybody put your insurance ears on, put your healthcare ears on, put your payer ears on, and understand that the system is definitively busted. And we've known this for a while.
Yeah.
But what Raja's bringing to the table with Plethy AI is going to be a game changer in every sense of the word. And so if you don't, as a listener, if you don't have a great understanding of how all this works in the background, and you either get a bill based on what's covered, what's not covered, or otherwise, or your company gets a bill, he's bringing some very informing solutions to the table.
Yeah. Yeah, and I'm looking forward to it. So without further ado, we welcome Raja Sundaram, CEO of Plethy AI. Raja, how are you today?
I'm doing very well. Good to see you, Mike D and Chris. That was one hell of a 90s rock anthem at the onset. That was it.
Were you laughing the whole time?
Yeah, it was awesome. Yeah.
Mm-hmm.
Reminded me of the hairband days.
Oh, yeah, brother.
Of AI.
Yeah, listen, they haven't died.
Yeah.
They're all coming back on vinyl.
Yeah. And then there's summer tours as well. Yeah.
Oh, yeah, unlimited.
They're all on Medicare, but they're still rocking.
And we serve them. Yeah.
Well, speaking of Medicare, private insurance, workers' comp, all of that fun stuff, we're going to switch gears a little bit here and talk about something a little bit different. Raja is the founder and CEO of Plethy AI. Is that right?
Plethy. Goes well.
Yeah.
Yeah. And well, first, why don't you tell us a little bit about what problem you're solving, kind of the vision that you have, and then let's kind of get into your company and what you've built and kind of where you are stage-wise. Yeah?
Absolutely. So the problem, in the way we looked at it, I think, Mike, a good starting point for this would be my background. So I don't have a background in medicine of any sort. I came out of Cisco Systems, came out of Virgin Hyperloop One, and came out of Boston Consulting. I'm the farthest away from healthcare. Somewhere along the way, I got an opportunity to play with Cisco Health Presence. And then after that, started, as I was read an article from World Health Organization on musculoskeletal and its impact to society. It's still there in Google. And it led me to understand the issues people face on recovery at home between clinic visits. So I thought about my own parents and I said, well, what will their experience be as we're all growing older, living longer, right? Which leads to the problem statements. So when you start looking at it, the first problem is poor patient engagement. Depending on who counts it, it's 5%, 11%, 21%. It doesn't matter. It's still really poor, which means people are taking the sheet of paper that the PT gives them, the doctor gives them on conservative care, pre-op, post-op, non-op, and coming home and watching Netflix, right? And this causes delayed recovery. The second part of the problem is the access to care problem that we are all facing. There aren't enough orthopedic surgeons. There aren't enough spine surgeons. There aren't enough PTs for an aging and older and active population. Just is. And the third part is looking at it from a payer standpoint, which is someone's got to pay for it, right? Someone either saves money or makes money, and you start thinking about it in that context. The frequency of the claims are going down, or it's flat, or tipping up a bit, but the cost of the claim is going up significantly. So if I am a carrier, I'm a payer, broadly speaking, then I want to make sure that I'm getting quality outcomes for the money that I'm spending, right? When you start thinking about these kinds of things, you start looking at it as there needs to be a new modality of care, a modality of care that addresses a whole person recovery and empowers patients to manage their care at home. We'll cover what that means from a whole person recovery. That's kind of how this came about. So partnered with a few folks, including Dr. Chapko, who's, I believe, head of neurosurgery at Ohio Health, and a few others to help us guide our pathway. And that's kind of how we got about here, Mike. Just how do you enable patients to manage their care at home?
So managing their care at home, I would tell you in my previous life, I was a physical therapist myself, and I did home health care. This was back in the 90s. So back when, the long-haired hard rockers were rocking, as we just heard in our intro music. But our population was all Medicare, mostly Medicare, some Medicaid, some private insurance. But to your point, patients, when they get home, oftentimes either they're overwhelmed with what to do, they don't know what to do, and that has a huge impact on their recovery in musculoskeletal, at least in my own personal professional experience. So how is Plethy solving for that? Talk about the patient journey. How do they get engaged with your platform, and how does that process or that systematic process work?
Yeah, so there are two parts to it. I'll first cover our philosophy on how we do the care, going back to what you said with your experience in home health, right? And once you get into that point of view, then we'll talk about how the clients come in and the patient's experience, but I'll have to kind of build into it who our customers are, because that shapes what the patient experience is, right? And so let's start with the first one, which is, look, when we started thinking about this thing, I previously talked about whole person recovery, the notion of intelligent musculoskeletal recovery. Let's pick that up. And then, because it begins to address your home healthcare experience, right? So it fundamentally takes this philosophy that, as we all know, recovery is not a straight line. There's going to be good days and bad hours.
Yeah.
Right. And so this notion of how do you meet the patient where they are becomes important. When you start thinking about it this way, then you start looking at outcomes. Wait a second, why is two people in different parts of the United States who have the same comorbidity, ethnicity, height, weight, BMI, etc., why does one recover faster than the other? You start thinking about it that way, you then realize that MSK outcomes are shaped not only by anatomy and physiology, but also by pain beliefs, fear, stress, sleep, functional behavior, work-life contact, relationships. So that is what a whole person approach to musculoskeletal recovery is. And so if you couple that along with data and insights, which is recovery along the horizontal telemetry of conservative care, whether it's surgery or non-surgery, if it's surgery, pre-surgical, post-surgical, 1 year out post-surgical, 2 years out post-surgical, then you're shifting from treating isolated symptoms to manage the entire care journey.
Mm-hmm.
Which is, it's not just about the clinic visits, it's not about the OR or the ASC, it's about this beginning to end of the journey, right?
Mm-hmm.
And so these two constructs is kind of what we do in the marketplace. We'll get more into how we do a biopsychosocial program, we'll get into that, which then leads to who are our clients, right? And therefore the patient journey that you asked about. So the clients, what we found was this. As you start looking at MSK, you begin to realize that MSK has multiple payer community who have different care abouts. So you could play soccer on the weekend, get injured, group health. A person drives to work, gets injured, automobile. Still MSK, gets injured at work, workers' comp, slips and falls in front of the building, During IC conditions, that's general liability, and so on. It's still musculoskeletal. And then
Mhm.
employee benefits for the covered entities, EB. All of these have different catabouts, different economics, and ROI that clients look for, right? And so we play today in workers' comp. We are the only solution in workers' comp. We play in spine, only solution in spine. We partner with VB Spine. And at the same time, we're the only ones in musculoskeletal for every joint of the body, every MSK indication, conservative pre-op, post-op, now. So in each of these, let's just take the healthcare and the insurance side of the house. So in the payer community, our patient gets sent to us in workers' comp when an injury occurs. And so we onboard them, we train them, we do assessment, and it's intelligence, a lot of data, not scraping from EHR. We generate our own data. At the same time, this notion of whole person recovery, we'll get into that in a little bit. In the case of the healthcare side, our clients are orthopedic groups, spine groups, health systems. And so at the first visit, the referral comes to us. And we take the same approach of onboarding. Our patient population, the youngest is 9-year-old, the oldest is 94 years old across the country. So it's a wide array, and each of them, we can go into dimensions of age groups and what it means. It's a different experience, and their expectation is different. So that's really how we approach it, Mike. It's a broad array.
It's a big deal too. And that's the attraction, is not just the problem solving elements of this, but it's the education as to what has produced this, right? It's people understanding that this could be possibly the biggest macro level viewpoint of the healthcare system and the way things get fixed from the payer perspective, from the hospital perspective, from the patient perspective, that I think we've ever experienced.
Yeah, it is. Look, different markets, payer groups have different expectations that shows up at different times. Let's take 3 simple examples. If you look at workers' comp, at the end of the day, what do they want? They want the injured worker to return to work. Because if we don't return to work, they have to hire somebody new, the risk profile goes up, head of risk doesn't love that. Second is they want their medical costs going down, they want their indemnity costs going down, and they want their disability costs going down. It's not just the medical spend, right? If it's a med-only claim, it's a medical spend, but many of them are indemnity claims as well. If you take the healthcare side of the house, now you're beginning to start seeing this focus from Medicare and others on outcomes. We've been talking about value-based care for a long time, but you're beginning to see this shift that is occurring in the marketplace, right? In terms of what they're looking for lower back on Medicare Part B and the implication it has to, I think, 8,000 something odd surgeons in 2027. If you're an employee benefits, you want to offer good benefits to your employees, but it is to a certain extent voluntary, right? If you use it, great. Doesn't mean you don't see a doctor. You can do alongside. It's just a nice to have. It's a different need. So when you start looking at these needs, Chris, we've decided to only play in spaces which ask for an outcome. If there is a quality outcome needed, that's a place we want to play in.
Mm-hmm.
If it's a nice to have, this is the old startup. Are you giving them an Advil, a Tylenol, or a vitamin, right? We want to play in the Advil, Tylenol space. We don't want to play in the vitamin space. There are others who play in that space. That's not us. We've been very deliberate that way.
So a patient falls or a patient gets hurt at work, hurts their back lifting something, works at one of the distribution centers here in Memphis, shipping MedTech and stuff all over the world. They go see their physician they're responsible for. That physician has a relationship as a client of Plethy. They're evaluated. Maybe it's a non-operative case, right? We wanted you to go through a rehabilitation program, and Plethy is part of that. Explain that just an experience.
Yeah, slight difference. The shipper in Memphis, Tennessee, will send the patient directly to us.
As
Their
opposed to
claims team, yes.
Okay.
So what happens, what we found, so think about this construct. In healthcare, we have a slip and fall, we go to a doctor. Doctor refers us, either we see the specialist directly from our GP, or go to our GP and then go to primary care and then get referred to a specialist, whichever the construct is on our coverage, right? And then we get the referral. So that's your healthcare model. But when you start thinking about workers' comp, our clients today are global Fortune 500, Fortune 100s, states, cities, counties, carriers, school districts, water districts, and so on. So there, what happens is you have this combination of, there is a claims adjuster when the claim gets filed, right? And so there's a claims handling process, there is a return to work planning, there's provider alignment that goes along with it. And in that construct, we will get referred the injured worker or the injured employee from the claims team. And yes, we work closely with the treating physician, we work closely with the PT or the OT, we work closely with the nurse case manager, but our referral comes from the quote unquote employer or the payer.
So maybe take it another level at the highest view, because Plethy is a revenue generating company. And you just stated, I think, the month over month growth, because you've got phenomenal things happening.
We're growing month over month 15% now, Chris.
Yeah. And
we're rolling out one large Fortune 100 a month.
Exactly. And I think, and if you can't mention them, don't mention them, but you've got a lot of clients at these massive macro levels, even states. I mean, it's a fascinating thing to me because it's organizations that obviously employ people, whether it's a governmental or otherwise.
Yeah, see, people don't think about it that way. You're spot on. So think about a city, right? Think about the 8th largest city in the United States, 7th or 8th. It's a client of ours. And you start looking at the city, then you start looking at people who are working in the city, who are employees in offices in the city. It's construction in the city. It's roadworks in the city. It's first responders in the city. And it is also people in the sanitation department in the city. And in this city happens to be by the port. So you can imagine people who are working there as well. So when you start looking at it as a state, now you have highway patrol to state employees to DMV employees. I mean, the list goes on and on. And so those are the souls that we cover.
Mm-hmm.
Yeah. And yes, they do see a doctor. We are not a replacement for a doctor, or we are not a replacement for a PT. We've kept ourselves very clean with regards to we will help the patient manage their care at home between clinic visits while reinforcing the need to go to clinic visits. That's how we've approached.
I see.
Which means recovery occurs quicker, faster, and that's how cost containment is done, not by cutting something. We don't see value in that.
And you bring up a great point. One of the first projects I had when I was at Richards before it became Smith & Nephew, and I was an intern, was 1989, cost containment in the 1990s. What's it going to look like? And this was brand new, right? It was an anomaly because nobody had ever talked about this. And yet what you're bringing to the table here is an answer, in my opinion, that we've been looking for more than 36 years.
See, this notion of cost containment is an interesting thing, Chris. As I started, so before I built anything, right, clearly I didn't know where the femur was in the body, right? And so Google was my friend. But besides that, it was talking to hospital CEOs, CFOs, orthopedic surgeons, neuro and spine surgeons to seek to understand what problem to solve, right? And one of the common themes that I would hear was the only mechanism of cost containment was to cut something.
Yes.
Let's cut 2 visits, whatever the visits are. I'm like, help me understand how cutting those 2 visits is going to drive quality outcomes, right? And it was more to do with am I passing the 90-day mark? Goodbye. It's no longer my risk to carry. I've transferred my risk, going back to insurance, right? I've transferred my risk somewhere. This is the period of time I'm going to manage my risk. That's not how you do this, right? Going back to the experience of what we were talking about, this notion of like, look, why is Johnny recovering faster than Stephen? Both of them have similar jobs. They're similar ethnicity, similar height, weight, BMI, comorbidity. Why is one recovering better than the other? Because if you know what it is, then you will know how to intervene, which then brings up, I'm going to put a pin on biopsychosocial and whole person recovery. Let's pull the pin out and talk about that. What we learned was this. What we learned really was this notion of rich data and insights that come in between clinic visits, right? And recovery signals, if you will, directly from the patient that is not available in the chart notes, in the electronic health records, or clinic records. Doesn't exist. There's no such concept. Now, when you dig deeper under it, what are they? The first really one is behavioral archetypes. So one of the interesting things about what we do is when a patient comes on board, we seek to understand like this notion of what they are challenged with, which is the psychological, social data and profile of how they like to be coached, cajoled, motivated, kick, push, empathy shown, along with their psychological background, what has pain cost them. Social data and support structure gives us a composite of the human being, right? So it's not just the bio aspect of how people move, engage, and respond in various stages of recovery, which is absolutely critical, right? Your active flexion of the knee getting to 120 degrees is crucial for quality outcome. But to get to that, who are they and what are they, right? That's the first archetype. Because the archetype then gives us an opportunity to engage them in the way they like to be engaged. Automatically think personalization at a grand scale, right? And so you now know how to motivate Chris versus Mike D, because it's completely different. How to nudge Chris versus Mike D to wake up this morning and do the exercises that Mike D gave him in the 1990s. I mean, it's like that is kind of how this thing works. And once you do that, along with it, you can identify delayed recovery risks, childhood trauma, depression, kinesiophobia, all of which is the difference between a labrum tear repair recovering in so many months versus twice the number of months. Head of risk will always tell you that it's the subset of claims. They always will throw out the 80-20 rule. It's 20% of the claims cost 80% of my money. If you can identify the needle in the haystack on week 1 or week 2 or through the early stages of recovery, and you start intervening it, that's how you do real cost containment and sustainable cost containment.
So you're doing cost, you're using virtual care to optimize outcomes, shorten recovery times, and by shortening recovery times and improving outcomes, you're containing the costs.
And de-risk before the claim escalates.
100%.
Whether you're on group health or an OC health or any other health, it's still a claim. There is still a TPA. There is still a bill review. That's the sustainable cost containment. So we turn around to large corporations, Mike, to your point, and we say, look, if it is complex surgical, we will save you so many dollars per claim. If it is medium surgical, we will save so much dollars per claim. We will get Johnny back against ODG 2 weeks earlier, 5 weeks earlier, 5 days earlier, return to work. If it is med-only claim, on this kind of med-only claim, we will not only ensure that we reduce your cost, we'll prevent it from going into a disability claim, indemnity claim, sorry. Or we will turn around and say, look, if it is a catastrophic claim and the person is a para, we will give them upper or lower body more mobility, So your long-term medical exposure is limited. That's how we talk about MSK.
Mm-hmm. Do you feel like, because obviously the gateway to the patients is through the corporate relationships, through the government relationships, things of that nature. The question I have is how much of your business model will require you as time goes on? Because I would think that you're going to become a household name. Okay. But how much of that needs to be a message that's direct to consumer? So you're hitting it from both the top and the bottom.
See, the B2B to C, we are now B2B, right? Our
Mhm.
clients are health systems, orthopedic groups, spine groups, or these payors in the broadest context in insurance.
Yep.
The model that people have attempted quite successfully is a B2B or a B2B to C model, which is, say, a benefits program like Hinge Health, as an example, right?
Mm-hmm.
Quite successful at what they do. And we play, at least it's nationwide complex. Ours is state by state complexity in workers' comp, right? And it's a pretty arduous process in what we have mastered. But the problem on B2C, particularly given the world of Aura rings and Whoop and everything else, is a complex proposition. It's a complex proposition for the very reason that you called out, Chris. You have to drive a lot of awareness.
Mm-hmm.
But then when you drive awareness, going back to the way the system works, who pays for it?
Yeah.
Because there is only so much out of pocket that people are willing to do. You talk to any orthopedic surgeon, they'll tell you about the pain of copays and co-insurances, right? We are not there yet. Do we see a trend of this technology empowering people to self-manage themselves? You're seeing that with data empowerment and electronic health record at your fingertips. You're seeing more and more of it. But we are in the early stages. Do I see us getting there? Yes. But do I see us today getting distributed through the various payor channels? That's kind of how we are playing it, because it's a sustainable proposition.
Mm-hmm. That's
because
great.
the end user also is very finicky on B2B, on B2C.
Yes.
Very much.
Because
Yeah,
it's
the
very hard
adoption.
for them to discern snake oil versus something that drives outcomes. It's very hard.
Yeah.
And if you're highly influenced by the next video you see on TikTok, I'm host.
Yeah. Well, patient compliance to any at-home recovery, whether it's medication compliance or it's exercise compliance or it's activity modification compliance, is a big problem.
See, that is the interesting trick. See, Mike, one of the things that whenever I do these podcasts that people will always gravitate to is the tech we have, Mike. And the problem is this: we have incredible tech. After all, a bunch of us, we are a combination of geek and Greek people, right? The medical people and uber geeks. The problem is it's not the tech. The incredible tech. Look, I didn't invent this category. You folks have seen these solutions for the knee for a long time before me. The problem that they all have is incredible tech with blinking LEDs, which are in the shelf. Not a single patient used it. So our trick was not the tech, was about this notion of human-centric design. How will people actually use it? So just to give you some simple examples of it. So let's do the numbers and then we'll kind of get into that. So if you're a native Spanish-speaking population, our patient engagement is 68%. If you're native English-speaking population, our patient engagement runs between 70 to 79%. And why the heck is the range? The range exists because we track by occupation. It varies depending on who you are and where you are. So if you see this broad array all the way from people who clean hotel rooms to people who work in mines, to manufacturing, to oil and natural gas, to first responders, to city employees or state employees or town employees, you have a broad array of occupation and the behavior is different. So you can't say he's 52 years old, therefore he's of certain ethnicity, he's going to behave. That's not true.
No.
We figure that out. So that's why
And there's too much of that.
Biopsychosocial works really well, right? And so what we found was what you said. It's patient engagement. Because if you can't engage them, the tech is on the shelf, right? And so the patient engagement, therefore, it's a whole series of micro steps. For example, we use computer vision AI. We do 3D. Quite effective. It's not just activity, it's clinical fidelity. We have a proprietary recovery dot that you could wear, think a sensor. We have to think about things like the sticker has to be such that you can peel it on and off. Twice a day, we're doing your home exercise programs. It shouldn't take off the skin or hair. The sensor is no recharging. It lasts 6 to 9 months through an episode of care. And in the cloud, I know the battery is down and I send them a new one. Why? Because men don't recharge products. We all bought a Fitbit or we all bought something in the past. And if you ask men what happens, there's enough studies that says utilization of these things by men goes down to 26% after 6 weeks.
That's interesting.
So then when you look at a Medicare age, particularly as you go past the 70s, then we don't have a menu on our app. It just is a care program that you have to go through, because don't give them options to pick and choose. I mean, you have to really think human-centric design on how to do this. We have coaches, because you require, in addition to AI and ML, you need a human touch. You need a human touch. And one of the common questions that get asked is, who requires onboarding? And the response is the people who predominantly require onboarding are people who forgot how to get their iTunes passwords back. We're doing password recovery. And I'm not kidding.
Yep.
And then if you have Google Play connected to Google Fit to track walking distance, it requires advanced algebra. Those are the kinds of things humans need support on. And so when you start looking at their entire experience, which is kind of what you asked, what does the patient experience look like? That becomes critical. And equally, Mike, to your previous question and what Chris was saying, the closed loop with the provider, a closed loop with the doctor to say, hey, look, our peers, we've gotten good at one thing, which is we will call on risk identified and call the PA along with the updates going through the platform and say, between today, tomorrow, and day after, Johnny's going to end up in the emergency room. This is what we see. Our job is not to diagnose, but our job is to ring the bell and submit the data and insights so that they can make the clinical decision that they need to make. Or this afternoon, we will call for one of our patients on their hip. It says, look, PT, Mike, you gave them 10 exercises. One of them is the supine heel slide with towel assist, which I've found that most human beings hate, and it creates discomfort. They're going to stop doing all their 10 exercises. How would you like to change the plan of care? PTs love that. PTs love the fact that someone's giving them heads up that this thing is not working, it's causing discomfort, so that they can change the plan of care in real time. Those are the kinds of micro steps that's required for quality outcomes.
Right.
That's really what we drive.
So to that
you can
point,
intervene sooner in care because you're capturing that data before they come back to visit you if you're a provider. Go ahead, Chris. Sorry.
Well, you've got the overall data. I mean, you've got the overall pool. When did you land the very first client? What year?
So just before COVID.
Okay.
When I came out of Hyperloop and seriously started looking at it, had an MVP and in Sacramento. It's the same surgeon who I first drew out Plethy on a napkin over bourbon. And that's how it started. He was the first West Coast Mako guy, highly successful, quite well known in this area. And that's how this journey started. So we did some cohort.
To this point, how many patients?
We've seen tens and
thousands
thousands of patients. Yeah,
Point
so
I'm
that's
getting
kind of
at
how we
is-
started with knee and then moved to hip. And then when we came out of COVID, we had done surgical, non-surgical, foot, ankle, knee, hip, lower back, spine, neck, shoulder, elbow, wrist, finger. Yeah.
So with that many patients, you must have a very predictive and extremely large data set.
Yeah, so what happens is the proactive outcomes that we've been able to drive along with the biopsychosocial, right? Every patient interactions now sharpens our prediction on predictive analytics. Look, one of the interesting things is like people talk about, we've written obviously peer-reviewed clinical studies on like, if you do this, Johnny gets back his range of motion 25 days earlier and, usual outcome papers. We've also written psychosocial related papers on MSK. For example, we figured out, Mike, you'll get a laugh out of this. Chris has seen this before. If your mood is good this morning, we figured out that patients spend 32 minutes on their care program. If the mood is bad that morning, they spend 2 minutes, and the mood is okay, they spend 7 minutes. By the way, yes, we have a peer-reviewed study on this. So you can now imagine if the mood is bad and your pain is high and your PHQ-8 is at 15, mildly depressed, you know what's going to happen.
Yeah.
You can very well predict outcomes. And we've gotten exceptionally good. And we're doing this by ethnicity, by occupation, and comorbidities and everything else to go with it. Yeah.
And I'll
That's
say this,
really what we are.
this will be my last comment because I want Mike to finish this out here. But the power of what's going to come out of this data is actually going to flush tons, and I mean this in the sense of tons of metadata that goes back years because it wasn't enough to arrive at the same conclusion that you're now bringing to the table. You're going to change how the doctors think, how the publishers think, how the podium speakers think. I mean, that's what I see.
That's kind of what we are beginning to say. It's like, look at the past. You asked about where we started to now. Where we started was we want to try it on a few patients, and could you give us, right? To now, people are like, I want to engage what I want to publish. I want to engage what I want to study. I want to engage, I want the data, right? Yeah, everyone that we interact with, one of the first questions, once they see our data set and outcomes, clinical outcomes, the first conversation is, would I be able to publish? Yeah.
You'll be well positioned when value-based care continues to mature.
Yeah.
It feels like there was a stop and start, in the mid 2010s, BPCS and all that. And it seemed like it lost some momentum, and now it's gained a lot of momentum.
See, we operated in the early days under BPCS and Blue Cross Blue Shield bundles and so on, right? And so we have quite a bit of experience in value-based care, as much as we do in fee-for-service and utility-based pricing models and everything else. It's all of the above, right, for lack of a better word. But here's the interesting thing. Mike, we live under that regime today. I might not live under a VBC, BPCS model in healthcare, but I live day in and day out, claim by claim, in workers' comp. Because in workers' comp, it is not unlike employee benefits where it's nice to have. Johnny has to return back to work. We have to prove cost containment. We have to prove quality recovery and maximum medical improvement, right? And enabling Johnny to get there. So I live under a VBC kind of a construct of show me value claim by claim by claim today. So when that time comes, you're spot on. When BBC or whatever version of it kicks back up, like we're there already. We live under that regime. So think about the ASM model, right? That got announced, the ambulatory specialty model. Even though it says heart and lower back, if a surgeon touches lower back, orthopedic and spine, it's their entire Medicare Part B book. It's not just the ones related to lower back. What is it, 9,000 surgeons or whatever the number is? They're starting plus or minus 9% in 2027 and 2028 and then 10%, and then 11. And what is interesting is if they go from orthopedic group 1 to orthopedic group 2, their number goes with them, and it's regionally analyzed. So it's coming, Mike.
Yeah.
It just got a new avatar, but it's there now. Yeah.
Yeah.
It's real. So you also see our health system partners are very cognizant of it.
Mm-hmm.
They want to make sure that they are in the list. If they're not in the list, 2 years from now, they're going to see a lower paycheck, right? It's real.
Right.
It's very real.
Yeah. Well, Raj, this was great. I mean, if people want to learn more about Plethy, if you're an investor, if you're interested in learning more, it sounds like you guys are maybe close to or in the midst of a fundraise. Where can they go to learn more, Raja, and potentially participate?
Yeah, no, absolutely. Yes, we are in the midst of a capital raise. As I was mentioning, we've been onboarding one large enterprise a month and 2 large health systems just this year, this year. So we are in the midst of a Series A. Finally decided to take the plunge. Simple way to reach me is raja@plethy.com or find me at LinkedIn, www.plethy.com, which would love a conversation.
Yeah. Outstanding. All right. All right, everybody. Raja, thanks so much. And we'll be rooting for you and watching you closely.
Thank you.
Because I do think that we're in the early innings of this kind of tech and virtual care and, optimizing for recovery. And it sounds like you've got a big head start. So thanks so much for with us and jamming with Chris and Mike D.
Thank you, brother.